Hello, everyone, and welcome to our webinar today entitled LSVT LOUD and LSVT Big, Applied to Neurological Conditions Beyond Parkinson's Disease. This webinar is being brought to you by LSVT Global, where we pride ourselves in innovation in science and integrity in practice. Your presenters today include myself. I'm Cynthia Fox. I'm a speech language pathologist. I am currently CEO and one of the co-founders of LSVT Global. I also serve as LSVT LOUD and LSVT Big faculty. And I'm joined by my colleague, Heather Cianci. She is a physical therapist and she is an expert LSVT Big clinician, among many other things that she's very expert at. And she also serves as one of our LSVT Big faculty. These are more detailed biographies of who we are. I will not go through these today, but you have them in your handouts for your reference. In terms of disclosures, all LSVT faculty have both financial and non-financial relationships with LSVT Global. Non-financial include a preference for LSVT LOUD and LSVT Big as treatment techniques. Financial relationships for the faculty today include myself as an employee of LSVT Global. I also have ownership interest in the company. And Ms. Cianci is a consultant for LSVT Global. Both of us receive lecture honorarium. A few quick logistics if this is the first time you're joining us for one of our webinars. All microphones are muted and will stay muted throughout the presentation. However, at the end, if you'd like to ask a question out loud, we'll unmute your microphone. Otherwise, you can type in questions at any time into the question panel. There are no cameras today, so if you have Zoom fatigue, sit back and relax. We can all just enjoy the slides and we'll entertain you with our voices. There is a handout. It was both emailed to you right prior to the start of the webinar. You can download it as well from the control panel that you have in your webinar or screen. And if for some reason neither of those options work, please feel free to email us at any time at info@lsvtglobal.com and we'd be happy to send the handout to you. At the end of the webinar, if you have 2 extra minutes, please stay on and fill out our quick survey. It provides us with really great feedback about additional topics we can provide or how to make these webinars even better. And let me just give a few comments about continuing education credits. This webinar is not ASHA or state registered for CEUs for speech, physical, or occupational therapy professionals. However, it may be used for self-reported CEU credit as a non-registered, non-pre-approved CEU activity. If you are a speech, physical, or occupational therapy professional and would like to self-report your activity, you can email webinars@lsvtglobal.com to request a certificate after the completion of the webinar. This will include your name, date, and duration. Licensing requirements differ by state, so please check to be sure that they accept non-registered or non-pre-approved CEU activities. And attendance for the full hour is required to earn that certificate. Our learning objectives today are really to explain the rationale for using LSVT LOUD and LSVT Big in conditions beyond Parkinson's disease. You'll be able to describe 6 non-PD diagnoses in adults and children where LSVT LOUD and or LSVT Big have been used, discuss the outcomes of effectiveness as self-rated by LSVT therapists in non-PD conditions, and some of the challenges associated with applying this treatment beyond PD. And finally, at the end, we'll give a brief outline of the process of decision-making when applying LSVT LOUD or LSVT Big beyond Parkinson's. So we know that speech, physical, and occupational therapies for people with neurological diagnoses are very much in need. When we talk about other conditions and other conditions beyond Parkinson's disease, it can include an entire range. And for anyone who is very new to LSVT, LSVT stands for Lee Silverman Voice Treatment. LSVT LOUD and LSVT Big were initially developed for people with Parkinson's. So when we talk about these may be individuals who've had stroke, MS, ataxias, atypical Parkinsonisms, cerebral palsy and Down syndrome, both in pediatric and adult applications, traumatic brain injury, spinal cord injury, focal fold paralysis, normal pressure hydrocephalus, aging concerns, both balance issues or voice problems. When we think about communication, we know there is a negative impact of dysarthria, which is a common motor speech challenge, on communication. This can decrease speech intelligibility, naturalness of speech. Many individuals encounter negative attitudes or discrimination. They have diminished engagement in communication. And it's a complex issue. It's challenging to treat at many different levels. In parallel, there's a negative impact of neural impairment on aging, on mobility and ADLs. And these might include things such as balance problems, gait and mobility challenges at home and in the community, difficulties with dressing, feeding, bathing, and other ADLs, fear of falling or actually falling, reduced activity, which can result in deconditioning. And just as the speech challenges are complex, so are mobility and ADL challenges. Treatment options as allied health professionals that we use. Obviously, these all are complementary, and depending upon the individual, we may be focusing one or multiple of these strategies. So we want to restore or improve function. In the case of developmental conditions, actually facilitate development of these functions. We want to promote the use of residual function, and these may be compensatory strategies. We want to maximize the external environment for communication and movement. And again, that's often in parallel with restoring function or promoting residual function. And in some cases, we may also incorporate assistive devices. These can be for communication. They may be text to speech or alternative augmentative communication devices. And for movement might be things such as assistive aids or using a walker, for example. As I mentioned, the LSVT protocols initially were developed for people with Parkinson's disease. LSVT LOUD being the speech therapy, LSVT Big being the occupational or physical therapy. These are delivered by LSVT certified therapists. So there is a 12-hour or 2-day course that individuals take to become LSVT certified. And after that time, then they're able to utilize the treatment protocols. LSVT is unique in its very long research history. 30+ years from the initial invention that began with Dr. Lorraine Ramig and her colleagues at the Lee Silverman Center for Parkinson's Disease in Scottsdale, Arizona, all the way back in the late 1980s, early 1990s. That was then the basis for what became a very systematic NIH-funded research program, a series of R01 studies, randomized controlled trials looking at the impact of LSVT LOUD, and LSVT Big development began in the early 2000s. In more recent years, we've spent a lot of time going beyond efficacy to looking at clinical implementation, which is training and certifying clinicians, improving accessibility. And actually one piece of phase 4 research is taking a treatment that has been proven efficacious and applying it to populations beyond the initial intended population. So why would we consider LSVT LOUD and LSVT Big beyond Parkinson's? As I just mentioned, it's a very established treatment approach with 30+ years, And in this phase 4 of research, we oftentimes apply to different populations. I think many of us are learning more about the power of randomized controlled trials, phase 4 type of research, given all of the news with the vaccines, other types of treatments that were developed for one condition but are being tried in COVID patients that are out there. And so what that means when you have such a rich research base is that you can have confidence as a therapist in the outcomes that we're achieving for our target population, Parkinson disease, but then you can have the ability to try this treatment in these other populations. So we focus on restoring residual function in damaged or degenerative conditions, but we may also be able to facilitate motor control for communication, gait, activities of daily living in neurodevelopmental diagnoses, which is an exciting area of our research. The key concepts of LSVT LOUD include target mode calibration. Our target is traditionally amplitude. That's a louder voice in the speech system and focusing on bigger movements in the body. The mode is intensive and high effort. And then calibration addresses barriers to generalization. And so how do we get what we can accomplish in the therapy room out into each individual person's daily functional activities? These key concepts of LSVT LOUD and Big, again, are applicable for a range of neurological disorders and conditions. When we look at the target and its initial development in Parkinson disease, what we typically saw in voice was that the voice was too soft, and in terms of movements are too small and slow. So we use this target of amplitude, think loud, move big, to override the small, soft movements and drive healthy vocal loudness, healthy amplitude of movement. And so we're never teaching anybody to be too loud or too big, but they need that cue just to get to normal loudness, normal amplitude of movement. What's been exciting in our research is that we see when we focus on a single cue, amplitude, loudness, bigness for the patient, what we see is that it triggers activations across the motor system, and we see cross-system effects. Not the topic that we'll talk about in depth here today, but there certainly are other webinars that go into that in great detail. Now, when we go beyond Parkinson disease, it may not always be that the target of amplitude is something that we want to use to override soft voice or small movements, but we can use a focus on amplitude and healthy amplitude to learn control of movement. So in some cases, training stability of normal loudness, training stability of bigness, and or improving strength is the goal. And that may be the case in ataxic movements, hyperkinetic movements, impulsivity, vocal hyperfunction, or generalized weakness, again, across either the speech mechanism or throughout the body. So think of amplitude as a target that we can use, again, to normalize and stabilize output. The mode of delivery, intensive and high effort, can be important for everybody. For healthy and disordered motor systems, it's key to affecting behavioral changes that last over time, and they are applicable for both adults and children. When we look at principles that drive activity-dependent neuroplasticity, these are some of the key principles that we want to incorporate into our treatment programs. Intensity. So intensive practice is important for maximal plasticity. We also need complexity. So we don't want to just do intensity of the same thing, same simple task over and over, but as treatment progresses, we can add complexity, environmental enrichment, and all of these have been shown to promote greater structural plasticity. Repetition matters, and so we need sufficient repetitions to drive that plasticity, and all three of our therapeutic disciplines, speech, PT, OT, have historically been way too low in the number of repetitions that we have patients complete. Salience matters. So practicing things that are rewarding, that are meaningful to each individual, drives plasticity, also activates basal ganglia circuitry. Timing matters. And so injury development can create fertile fields for plasticity, but they need some kind of behavior. And by behavior, what we do in terms of treatment to make that happen. Timing is different for different types of disorders, and this is always something to keep in mind. So with Parkinson's, for example, we always feel the earlier the better, but if we're in a phase of acute stroke, earlier may not be better, and it could potentially be neurotoxic. So we have to take these principles, in particular the one of timing, and consider it depending upon the medical diagnosis. And finally, we want to train to the deficits. And so one of those deficits in Parkinson's has been hypokinesia. But when we look to these other disorders, we can look to amplitude or amplitude-like deficits that may be part of the presentation and use those as a target. In terms of intensity and high effort, both LSVT LOUD and LSVT Big are delivered by certified therapists and they're individual one-on-one interventions. They are each delivered 4 consecutive days a week for 4 consecutive weeks. There's 16 sessions of treatment in 1 month's time. These are 60-minute, 1-hour treatment sessions. You have daily carryover assignments, which are all 30 days of the month, as well as daily homework practice all 30 days of the month, with the goal of establishing lifelong habits of practice for our patients at the end of treatment. So they are intensive, but the reality is they're 16 hours. And many of these individuals live with these conditions or challenges their entire lifetime, if they're developmental, or for many, many years in cases of neurodegeneration or neural injury. So it really is a small, focused time to have a positive impact on communication, mobility, activities of daily living. While we have our core exercises, we also have to link to function and task-specific practice that's personalized for each client. And this is absolutely vital for generalization, and it's part of the concept of calibration. So while we have a standardized protocol, we can incorporate tasks that are meaningful and salient to each person, which enhances their motivation. We link the program to their individualized functional goals, and we incorporate hobbies and passions. And this helps us achieve self-realization and improved communication, movement, gait, and ADLs. So with that context, we can think about LSVT helping by using the principles of neuroplasticity. We incorporate blocked, serial, and random motor practice, which are consistent with motor learning principles. We provide extrinsic feedback using our 4 teaching techniques of modeling, shaping, driving, and stabilizing. And the clients repeatedly learn how they are doing and what needs to be improved. And we promote intrinsic feedback through the teaching principle of calibration. This helps clients reset their internal motor program, which may facilitate generalizability to other tasks and activities outside of the clinic. These teaching techniques and principles are things that we go into in great detail when we do our full LSVT LOUD or LSVT Big training and certification. So an important take-home message is this: the treatment is not changed or modified when delivered beyond Parkinson's. In that sense, LSVT is LSVT is LSVT, and we deliver these LOUD, LSVT LOUD, or LSVT Big per protocol. We don't take parts of the treatment and apply them beyond Parkinson's. If we believe that it has the ability to be effective, we do the entire protocol or none at all. And the core fundamentals of intensity, complexity, repetition, task specificity, and saliency are very applicable beyond PD. And we'll talk about ways that we can adapt some of the exercises to take into account all kinds of communication or mobility issues, but the core and the heart of the treatment remains consistent. Let's talk about the real-world clinical use, first of LSVT LOUD in non-Parkinson's conditions, and then I'll turn it over to Heather, who will walk us through the real-world use in condition LSVT Big in non-PD conditions. So last year we were interested in who's using LSVT and how are they using it. And so we sent a 13-question survey to our LSVT LOUD speech therapist in 6 English-speaking countries, as the survey was in English. We had 248 therapists representing all 6 countries respond. 95% of them were professionals, 5% students. 94% of all respondents said they were providing LSVT LOUD to clients with Parkinson's. 75% reported using this treatment with adults with non-Parkinson diagnoses. So a large percentage were going beyond idiopathic Parkinson disease. 15% were reporting using LSVT LOUD with children. This first graph is looking at movement disorders or non-Parkinson disorders that would be under the typical umbrella of movement disorders. And the 4 most common movement disorders were progressive supranuclear palsy, multisystem atrophy, Lewy body dementia, and ataxia. You can see that usage ranged from 30 to 14%. And effectiveness was rated on a 5-point scale from very effective to not effective. And the combined ratings of therapists saying the treatment in a particular population was very effective and somewhat effective was quite high, 75% for PSP, 79% for MSA, 81% for Lewy body dementia, and 88% for ataxia. These are publications in the literature, not randomized controlled trials, but case studies, single subject design, and small group designs on some of these populations, PSP and ataxia and other Parkinson plus syndromes. For ataxia, this is a case study that was published in 2003. And what we have here in these triangles are vowel space triangles. And if you're not familiar with these, the pre-space in white would be considered compressed, and that's consistent with perhaps reduced speech intelligibility, where the post-vowel triangle is expanded. It's more normalized after treatment. And what we're going to do now is listen to an audio sample of this woman pre-treatment and then immediately following LSVT LOUD.
Describe your speech and voice.
When I'm really thinking that sometimes I'm telling them over monitoring, or when I'm under monitoring, it's forced at times. It can be breathy, heavy. My voice gets tired, so it's a real effort at times. And I really notice when people say, "What'd you say?" that I'm really inaudible to them.
And now post.
What have you noticed?
I've noticed that it's easier for people to understand me while I am talking. I don't get a lot of "what did you say" constantly.
Do you feel like you do any more talking now that you've had this therapy?
Yes, I do much more practicing and not as much nodding.
Great.
Okay, so we had a nice impact on loudness, but really, again, I think that idea of controlling loudness so that she can manage the modulation, and we hear some of that nice carryover into speech clarity or speech intelligibility.
Your speech.
Now we looked at application outside of movement disorders. And so these top 4 diagnoses that LSVT LOUD clinicians were using included dysarthria secondary to stroke, multiple sclerosis, vocal fold paralysis, and the aging voice or presbyophonia. Usage again ranged from 17 to 34%, and now effectiveness is even higher, so effective or somewhat effective from 91 to 96%. Similarly, we have some very nice published articles that range from MS, secondary to stroke, TBI, the aging voice, and most recently, just this past week, an adult with cerebral palsy. So some exciting literature there that you can read if you're interested in learning more. What I'll share with you now here is a similar audio sample scenario where we'll hear a gentleman. He was post-stroke. He was not acute stroke. This was chronic stroke. Immediately post-stroke, he had issues with language, cognition, swallowing that took priority. But at some point, challenges with his speech intelligibility, the dysarthria, became more challenging. And so we'll listen to his pre, followed by his post sample.
What do you think about your voice?
Well, my voice sounds pinched, and I get out of breath easily.
How often do you feel that people have a hard time understanding you?
Every day.
Every day? Have you noticed any changes in
Oh yes, oh yes. Well, I find that I speak more distinctly, and I find that my intonation is better, and I surely speak louder.
Very good. Has anyone commented it's easier to understand?
Oh yes, oh yeah.
Tell me about
Several people that I have been in company with, friends and neighbors and all.
Okay, so another example, again, his speech is not perfect at the end of treatment, but that improvement in loudness gave him some stability, gave him less breathlessness where he felt like he was running out of breath all the time, and some of that improvement that spilled over to articulation.
What do you think?
The last group that I'll share before we move on to LSVT Big were some of the survey results from children. Using LSVT Loud in children is more advanced than the consideration of using LSVT Big in children, although there is interest growing there. And you'll see that it's also newer in that the usage was much lower, from 7% in CP, 5% Down syndrome, 2% in children who have vocal fold paralysis, and 2% in developmental disorders. The effectiveness, however, in CP and Down syndrome was very high, very good in vocal fold paralysis, and at 50% in developmental disorders. We have many published articles now in children with CP and Down syndrome, and I'd just like to point out that these articles, outcome measures range from acoustic, perceptual, physiological, and we even have 2 imaging studies, both structural imaging with DTI and as well as functional imaging. So we're pretty excited about the potential and the expansion of LSVT in pediatric populations. Just to whet your appetite, I'll play an example of a little girl with Down syndrome. She was 5 years old, and you're going to hear her say her phrase, "I need help" pre, followed by "I need help" post. These figures are the microphone signal on top in green and the spectrogram of that speech signal below.
I need help. I need help.
And now post.
I need help. I need help.
So again, you can hear that power that focusing on loudness gives her speech, and we see some of that spill over again as well into speech articulation. So with that introduction and sharing of information about LSVT Loud, I'm now going to turn the presentation over to Heather, and she will give you the parallel in thinking about LSVT Big in non-Parkinson's conditions.
Thank you so much, Dr. Fox. I really enjoyed listening to those audio files. I think it's just so amazing to see the depth and breadth of what LSVT Loud and now LSVT Big can really bring to people who are living with a whole host of neurological conditions. So Dr. Fox had talked about the online survey that was done for the LSVT Loud clinicians, and this was also done for the LSVT Big clinicians in looking at, again, the usage and effectiveness of using LSVT Big in patients who don't have Parkinson's disease. So we were up to over 541 therapists really responded. So that's a great response rate. And you can see that we had 97% were professionals and 3% were students. So let's look at the next slide and we'll talk about how this was broken down. You can see that when we look under the movement disorder category, so conditions that may be similar in nature, but not exactly to Parkinson's disease, you can see that we have about a quarter of the percentage of therapists out there using it. So people using it on patients who have secondary Parkinsonism, so that might be something from a head trauma or due to long-term dosage of narcotics or different medications that can cause that. You can see also in the use of people who have Lewy body dementia. And then lastly, individuals who have something called PSP, which is progressive supranuclear palsy. And I think although the number in the amount of usage is low, the thing that really sparks my attention and makes me feel hopeful is the percentage of the effectiveness. So you can see with those folks with secondary PD, we're over 90%. And in those folks with Lewy body and PSP, we're seeing in the 70s and plus. So a lot of excitement that's coming from hearing that these clinicians all across the globe are really showing good effectiveness with using LSVT Big. On our next slide, we break it down and we talk about some of the other disorders that are out there. And I'm going to spend a little bit more time as we go forward talking about stroke in particular. But you can see that 40% of clinicians who were surveyed are using it for stroke. We have almost 40% again there for people who are having balance issues with aging, and a smaller percentage for those with MS. But again, I say to you, look at the column for effectiveness. Again, we're seeing 82 and higher, especially look at that middle one there for aging and balance. And we know as clinicians that we are seeing people live much longer and live healthier and be able to continue on with a whole host of age-related things that are going on. You know, I personally in my own clinic, I've had people who have gone through LSVT Big and the loved one or family member says, you know what, I've got some issues too. I don't have Parkinson's, but I think this might be something for me. And we've gone ahead and done it and had some wonderful, wonderful effectiveness for them. Next slide. So I'm going to back up now and talk more about stroke in particular. So there have been some really nice case studies of late that have been coming out looking at using LSVT Big and not even using it in someone who has had a new stroke, but we're looking at people who are into the late stages or chronic stages of stroke. So this first study here was really looking at whether LSVT Big could have an impact on occupational goals, meaning things that people wanted to do. And they had two clients, one who had a stroke 3 years ago, and then someone much longer, up to 12 years ago. And what they did was they looked at using the full protocol of LSVT Big, meaning that it was 4 times a week for 4 weeks. And they trained these clients on 3 out of 6 of their chosen tasks. So they asked those patients, you know, what is it functionally and occupationally that you're having difficulty with that you would like to improve upon? And the outcome measurement tools that they used were first the COPM, which is the Canadian Occupational Performance Measurement, and then also the everyday arm use in the community and home. And they repeatedly used those measures throughout those 4 weeks. And what they found in the results from doing this was that the performance improved on either the self-assessment, meaning that what that patient was reporting at how they were doing, as well as the blinded rater in everything except for one activity. And the thing again that I want to really point out to you is that things that they didn't even work on, so untrained activities, things that actually were practiced with the help of that therapist, those 2 patients were actually showing improvements on. So this was a really nice stepping stone to say, you know what, we could make some great impacts on people with chronic stroke. Let's look at the next slide. And what they were saying as well was, it's not just about cardiovascular fitness. It's not just about feeling stronger, about having better range of motion. It's also about the confidence, the quality of life. And the researchers really said that the improved confidence and engagement in valued occupations was something that they were able to see, and that was something that was of critical importance for these two patients. And they went on to say that LSVT Big is a promising intervention to improve occupational performance. And again, further research is required to clarify which elements of the program were essential to improving occupational performance. But again, a great starting point for us to say, you know what, we can make some good impact. Now, this was just a study of one person. This is a case study of a woman who also had a stroke. She had had the stroke over 2 years before she started the LSVT Big. And what they found was that she had some really nice improvements in performance and satisfaction, again, on that same outcome measurement tool, the Canadian Occupational Performance Measurement, as well as the Wolf motor function, and she was able to improve the active range of motion on her affected arm. She had what they described as mild to moderate hemiparesis of her left arm. Her name was Brenda, and they said the improvements that Brenda has made in her performance of occupations and engagement in new occupations reflect the saliency of the LSVT Big intervention. So again, this one further supports that there is generalization and carryover into things that she wasn't even practicing. She had improved confidence in what she was doing. And this is another one with stroke where a group of 5 patients was treated again with the full protocol 4 times a week for 4 weeks using occupational therapy. And their objective was really to determine, was it feasible and acceptable to use LSVT Big for people who had a stroke, and really to determine preliminary clinical effects. How did that intervention actually improve their occupational performance and the function of that arm? What they found was absolutely LSVT Big, again, was feasible for folks with chronic stroke. These people did make nice improvements on their occupational performance, motor function, so use of that arm, as well as quality of life. And again, some of the participants also self-reported engaging in non-prescribed activities in the home, meaning that generalization of improvements to performance in those related activities. So you're really seeing a nice common thread throughout those 3 studies. So in summary of what we just talked about, we really are showing that LSVT does have the possibility to be helpful in improving function and in the upper body extremity use of some clients with stroke. And looking at occupational-based individual goals in this population really showed that, yes, all of these people made the improvements. Using these outcome measurement tools of occupational performance is really useful to the clinician so that they can identify tasks which, again, are meaningful or salient to the client. So again, people want to work on things that are important to them, and they have more motivation to do so. Now, of course, with any research that's out there, there are limitations. Again, these were case studies, not able to really extrapolate or determine which elements of the program were the specific contributions to the improvements. Some did lack a blinded assessor. We have to be careful about saying that we can generalize this to all people with stroke. And again, knowing that it is a small sample size, and also people living in a rural area who had difficulty with access to getting to places for therapy can pose a challenge. So this is a recent study that came out looking at someone with NPH, which is normal pressure hydrocephalus. And this was a gentleman who had had NPH for quite some time. You can see for 16 years, the diagnosis of this came out of multiple falls. He again went through the intervention of LSVT Big, did have 1 cancellation. And because of this patient's difficulty with distractibility, he actually had to have additional time to do this. So instead of a 1-hour session, he had a 1.5-hour session. And after he was discharged, he was reassessed at about 7.5 months, and he needed to have 5 of what we call tune-up sessions, meaning that he needed to have more elements of being driven and motivated and to bring everything back up to the amplitude where it once was. Now, looking at those outcome scores, you can see that the Berg, which is a test of balance and a little bit of gait, as well as the ABC, which is the Activities Balance Confidence Scale, they were able to be improved beyond this minimal determination of this clinical point. Now, there were no changes in the tug ×3, and the tug is meaning you get up from the chair, you walk a certain distance, turn around and come back. 5 times sit to stand, you get up as quickly as you can from the chair 5 times. So even though there weren't indications of a numerical improvement in those two, we did see that he no longer fell backwards when he was moving from sit to stand, and that he was able to take larger steps, which mean he took a less number of steps when he was turning. The other thing was that he had an easier time and it took him less time to transfer from the floor. So again, it's not all just about speed with these people. It's about the quality of the movement, and by the bigness of the movement, we get better functionality for those patients. So we do recognize that there are challenges that are associated when we are applying either LSVT LOUD or LSVT Big beyond our patients with Parkinson's disease. And we do know that cognitive impairments really are something that were probably one of the most challenging things in order to have success for that. And the intensity of the dosage was the greatest logistical challenge, that intensity of the 4 times a week. So yes, those are recognizable problems, but easily can be worked around, just like we do with our clients with PD. So what are we going to do? How do we maximize using both LSVT LOUD and LSVT Big for those folks with the cognitive challenges? Well, you're absolutely going to want to increase the repetitions, meaning that they get more of a chance to practice it. And again, they don't have to hold it for as long, and then you can get more repetitions. If people are fatigued, we obviously want to give them more time for rest breaks. And again, when we are using LSVT LOUD, we want to persist at that phrase and sentence level where we're doing it over and over again. Or for the functional movements, for the ADLs with Big, if they're having difficulty when things are deteriorating, we have to be careful with how hard we're pushing them. So we have to make sure that we're giving them enough push, but also giving them the time they need. If they have family members, friends, any kind of support system to help with carryover outside of the clinic. And again, for folks who have any kind of visual or language impairments, we might have to change the materials to make it bigger, to make it louder, to put it in a different version. Maybe someone doesn't do well with it on a paper and they need to hear it, or maybe they need to have it in a video format. And again, we can always add additional visits onto that. It doesn't just end at that 16th session. We can continue out and we can get that patient to come back in for more frequent follow-ups. One of the things we really don't want you to do is not to alter the core protocol. So we still continue with those 4 times a week for 4 weeks with all of the great things that we do. We don't want to give fewer sessions in a shorter period of time. We don't want to eliminate any of the treatment tasks. So that means the functional phrases, the functional tasks that patients are doing. And we have to make sure that that's what's imperative to hold on to. We also don't want to take away any of those core elements. Remember, that target is the amplitude. It's the amplitude of the voice and it's the amplitude of the movement. And we want to make sure that we're working towards consistency with how we do it and getting that person to understand calibration, to feel how they can correct it and they understand what to do. We also have to be careful as clinicians that for our folks with cognitive problems, they're going to be a little slower with processing, a little bit slower with getting things back out. So please watch your speed when you're doing it and kind of tailor your speed to what that patient needs. So talking about the alternative delivery mechanisms of both LSVT LOUD and LSVT Big, we like to say that if there is one good thing that came out of this pandemic, it is the mechanism of telepractice and telehealth, something that we as therapists have been pushing for a very long time, really not getting too much with the PT and OT world, somewhat in speech, but this has been wonderful. This has really opened up telepractice, not only for LSVT LOUD, but also LSVT Big. The other thing that we've had for quite some time and continues to be wonderful in the world of LSVT LOUD is the LSVT Companion Series. And that's something that really can be motivational and helpful for folks at home. So if you have questions about that kind of stuff, we're happy to answer that more at the end of this session. So general considerations. Remember, again, LSVT Loud and LSVT Big are not for everyone. Remember, this is simply another tool in your toolbox. You, as the clinician, have to make that guided decision as to what is best for that. And there are, in fact, diagnoses that we really don't want to use that are contraindicated. For anyone who's in the acute phase of myasthenia gravis, this is not going to be best for them. Of course, with ALS, anyone who's in an acute exacerbation of MS and people who are really newly or freshly diagnosed with CVA, again, probably not things that we want to be using for them. So you might be thinking to yourself, how do I know if I can use LSVT Loud and LSVT Big for someone who doesn't have Parkinson's? It's another disorder. Well, first thing you want to do is you want to evaluate that diagnosis and think about what's the rationale for focusing on improving the voice or movement. What are those deficits? What is it that really needs to be fixed? Then think back, are there any kind of medical contraindications that I need to be worried about as to why this wouldn't be good? If you come up with saying, you know what, I think I have good clinical rationale based on the physiology of this communication or movement disorder, you can always do a week of what we call stimulability testing. And that means you see that patient for 4 times a week and you really push them hard throughout, just like you would if you were thinking about going the full time. If you're really starting to see some nice improvements and that patient is able to bring about the change by your focus on the intensity, on how you're shaping people, on how you're really helping them, then they're probably a good candidate. So get that week of stimulability testing in, and then you're going to assess them and then proceed accordingly to how you think it's best for that patient. And I really like to say, and I love this slide, give everyone a chance. There have been so many times over my career where I just get mad at myself and I think, why did I second guess this patient's ability? That wasn't fair of me. That wasn't right of me. You don't want to discount successful treatment options just because something is very severe, advanced, or complex. Many times with these conditions, the best form of treatment is within the rehab therapy services. There may not be a medication, there may not be a great treatment for this. So even if someone is in the later stages or really is a challenging condition, always say give it a chance. And the outcomes can be really impressive and greatly improve the quality of life, not only for that patient living with it, but also for the family members. It may not be that we get that patient to be quote unquote perfect in their speech or perfect in their gait, but the ability to make a person safer, to make a person more intelligible in their speech, to have a family member not have to work so hard to help someone, that can be really helpful and positive for them. So in summary, we want to share with you that we really do feel there is solid rationale for using both LSVT Loud and LSVT Big in conditions beyond Parkinson's disease, and that we're starting to see some really nice research evidence for select populations. We talked about the case studies, the single subject designs, and some of the small group designs. Again, what we're seeing is that the effectiveness as rated by those therapists using this for non-PD conditions has been really high. And really, that's what's most important. We are seeing the effectiveness coming out. Again, we acknowledge that there are challenges associated with this. So again, we always want to talk through things and try and work with that patient to make it work. And again, recognize that there are techniques to maximize those outcomes and address those problems and challenges. So it's not just an open and shut case that, nope, they can't do it. Let's see if we can think out of the box and kind of brainstorm. Again, if you're not sure if someone is appropriate for LSVT Loud or LSVT Big, we really, really want to say to you, go ahead, use stimulability testing and try that. See what's going on, see how they work, and use your clinical expertise to determine who's going to be appropriate and best for that. So before we get to the questions, we just want to remind you of a wonderful webinar that's going to be next month on Wednesday, April the 21st, again at the same time frame from 2 to 3 p.m. That's Eastern Standard Time. And this is entitled Improving Your Fine Skills Through LSVT Big. So we know that fine motor coordination and things that are already small can get even smaller with people with Parkinson's disease. So if you're interested in different ways on talking about this and how we can help people, please join us. We also invite your clients, invite some of your colleagues who may not be trained in LSVT Big. We would love to have people join us for that. So before I hand this over to Dr. Fox, I just want to remind you how to ask questions. The easiest and most efficient and effective way is really go ahead and look in your side panel there under the questions tab. Go ahead and type that in there. We'll read it out loud and we'll answer to the best of our ability. If we do not get to your question by the end of this webinar, feel free to email us at info@LSVT Global. We have an expert who is available to answer that question. And remember, we do offer wonderful office hours. So for LSVT Big, that's on Tuesdays from 8 to 8:30 Eastern Time. And for LSVT Loud, that's on Wednesdays, also from 8 to 8:30 Eastern Time. And that's just an open door policy where you can come aboard and ask us any and every question, and we'll spend 30 minutes together trying to help you. So we really want to thank you for your time for this. I do want to remind you, sorry, Cynthia, after we do in an answer session, please do stay on for just a moment or two, complete that survey. It really helps us to help you in our planning for future webinars.
Excellent. Thank you, Heather. And so now we will, we have about 10 minutes here to answer your questions. And I see that they are coming in, so I will just start at the top and go down. So Heather, this first one, I'll have you answer it related to movement, and then I can answer it related to speech. The question is, how long post-stroke might you consider using this approach?
That's a great question. You want to make sure that obviously first your patient is clinically stable, right? So they are returned to the home, they're going to finish all of the other therapy that they would have had, making sure that their coverage is eligible for that. But I think once someone is past that acute phase and they've gone through probably, a lot of people will do acute care and then they'll do post therapy where they will have inpatient rehab, home care, and then into outpatient. I think it's a great technique for the outpatient clinic. I don't know that in the acute care phase it's going to be applicable or in the early rehab phase, but I think once people get into outpatient, that could be a great time to start it.
Great. And I would say that's similar for LSVT LOUD. Also, we recognize for LSVT LOUD, many times dysarthria is not the first problem. Rather language, swallowing, sometimes cognition are treatments that take priority. And it may only be in a further later chronic stage when the dysarthria really needs to be addressed, and LSVT LOUD would be appropriate. Question, how can we do further training? You can do training in multiple ways. We have our online LSVT LOUD and LSVT Big training and certification courses. These are asynchronous courses that you can do anytime at your own pace. You have 60 days access to the course from the point of purchase. We also do, right now for 2021, our live courses have pivoted to virtual live courses. These are a combination of some modules that are done online, and then we have 2 5-hour days together virtually, where you have live interaction with faculty as well as other participants. And on our website, lsvtglobal.com, there's a giant orange button that says Get LSVT Certified. Click that and follow the steps and you can learn more. What does CVA mean, Heather?
Sorry about that. That is a cerebrovascular accident. So that is actually where someone, there's blood flow blocked to the brain. That's another name for a stroke, CVA.
Great. I have a patient with dyspraxia of speech following stroke. He loves singing. Is there any research on efficacy of Apraxia patients? We've not done direct Apraxia and looked at Apraxia in specifically, we certainly, in some of the individuals post-stroke and some of our children with cerebral palsy, there's multiple, the complex speech challenges of which apraxia of speech has been part of that. I would say we take it on a case-by-case basis. If there's really a respiratory laryngeal component to their apraxia, it's certainly possible that we can see some improvements in these individuals. So as Heather said, stimulability testing is the way to start. If we like what we see in stimulability, we do trial treatment. And in some cases, yes, and in some cases, possibly no. Just to clarify, are the weekly office hours 8 to 8:30 a.m. or p.m.? They are 8 to 8:30 p.m. Eastern time in the United States. And so those occur weekly. Let's see, Heather, how do we document LSVT Big when treating a patient with another neurological condition? Do we still document the same as with traditional Parkinson disease?
And simple answer is yes. Yeah, you would document just as you would document how the patient completed the 7 maximal daily exercises, what they did with their functional component tasks, their gait, their hierarchy, and you're still going to give them a carryover. So yes, again, it is the same thing. It's no different. Remember that you have the freedom to use LSVT Big for any patient you seem to think that it's rational for.
Great. Can you elaborate on the aging conditions as diagnosis? And I'll take a crack at it from speech, Heather, and then I'll hand it over to you. Sure, so it's really just aging voice. Presbyphonia in the speech mechanism. These are individuals, they may have some documented physiological changes like bowing of the vocal folds, and we look to where it really starts to impact function. So difficulty being heard or understood, oftentimes it may be impacting occupation, in particular those who may still be teaching, certainly lawyers where the soft voice, hoarse voice, changes in voice quality can really be a challenge, and that's where LSVT Big or LOUD can be helpful. And so Heather, to you for LSVT Big.
Yep, when we're talking about that aging population with changes in balance, probably 2 main things. You're going to work with that population of people who have sarcopenia, where they're getting really weak. We've had a lot of folks over the pandemic who have gotten significantly weaker due to just inactivity. And we know the older we get, the faster we get weak, the shorter amount of time that we sit. The other one would probably be your folks who have something called multifactorial gait dysfunction. And those are the folks who they're starting to have balance problems, they're starting to have falls, but the doctors have really kind of ruled out any kind of neurological problem for that. You know, it's sort of that, what's going on here? You do have a classification of people with issues with neuropathy that could or could not be due to diabetes or impingements in the spine, things like that. But then there's just folks with just general aging, like I said, with sarcopenia, and that can be problematic for them and impact the balance.
Great. And one more question for you, Heather. Can you really get through the whole LSVT Big program in an hour?
Absolutely, absolutely. I think the mistake that a lot of new or first-time clinicians make is that they spend way too much time trying to fix every little thing early on. And they try to get through all of the repetitions and all of the hold times of the exercises. Remember, you have 4 times a week for 4 weeks. You can start out slow and grow it. You can push someone just as intensely with 3 repetitions as you can with 8 repetitions. So if you bring down the number of repetitions and you bring down the hold time for the initiating exercises, you're going to have plenty of time to get through all of that other great functional engagement that you want. So yes, absolutely 100% available and able to do. And I can speak from experience because I see lots of people doing this, and no way I could run one patient into the next time slot. So we've got to make it happen.
Great, thank you. Here's a question. If we've taken the LSVT course, but it was more than 12 years ago, can we still take a less expensive recertification class? And the answer is yes. If it's been more than 12 years ago, we will require the full LSVT course again, whether it's LSVT LOUD or LSVT Big. And again, that can be the 12-hour online or a 2-day virtual course, but you can take it at the reduced rate of the $200 versus the initial certification rate of the $580, and you'll get full CE credit, etc. again for that. So hopefully we'd really enjoy you to come back, get yourself recertified. There's so much we've learned over the past 12 years. It's incredible. And I think that anybody who has done that in the past has found the value of getting back into the LSVT mode and being able to deliver the treatment. Okay, wow, our timing is perfect. Looks like we're right at the top of the hour. We have all your questions answered. Again, if you have additional questions at any time, send them to info or webinars@lsvtglobal.com. Heather, thank you so much for sharing your expertise. Thank you everyone who has joined us, and we hope we catch you next month at our next webinar. Thank you.